everybody, it's Karen Anderson here with Aortic. Hope for a very fun and special live Q&A tonight. But before I get started, I'm going to ask everybody, please do me a favor. Click like down there, click subscribe, click the bell so that you're notified every time we go live for events like this, because you'll see by looking at our event section, we have a busy May, so you don't want to miss anything. And you do have an opportunity to ask questions live in the comments section below. Just know they're going to live out here forever. So if you want to ask a question anonymously, there is a link to an anonymous form, and you can do that, and we will be more than happy to take your questions. So I'm so excited about tonight. We did this when you were like extremely pregnant with your daughter. We did this once, and this is really just diving right into why PT? Why is physical therapy a really good option? And it can be used as an enhancement towards or an addition to with cardiac rehab, or if you're not approved for cardiac rehab, what would happen in physical therapy? And I think it's important because I don't really see there being any con to it at all. I'm a huge like supporter and seller of PT. But before we get into all of that, just note before I even start, so I can say it once, I'm not a physician. None of this information is supposed to substitute what you receive from your own physicians, just supposed to get that conversation started. So to start this conversation, I'm going to let Amy go ahead and start with just telling you a little bit about herself and her background, and then we're going to just get into it.
Well, hello, everyone. I'm Amy Klumpp. I'm a PT. I've been a PT for 13 years. I don't specialize in treating patients with aortic aneurysm. I've just had a few on my caseload. Mostly Karen introduced me to that and got me more comfortable treating it. But I mostly treat in orthopedics. I have my orthopedic clinical specialization, and I'm a doctorate in physical therapy. So I love treating a variety of, not just orthopedics, a variety of patients in here. But I have had a couple patients with dissecting aortic aneurysms, and it's a good eye opener for people that it's an option out there. So we're going to talk more about the specifics, because I myself have never been in cardiac rehab. I can only tell you general information about it, but I'm here to just advocate for the PT side of it and answer any questions you have.
So let's jump into this, and we're going to talk a lot tonight about my experience because I have no shame in the game. I love to share information. Maybe hopefully you find it thought-provoking a little bit, but let's go backwards. Little over 10 years. I met Amy in 2014. I had just finished the 10K for what was it, Crohn's and colitis. It was the rock and roll marathon. I just walked really fast, not very far, but it destroyed my feet. It destroyed them. It destroyed them. I had very bad plantar fasciitis, and I came into this clinic, and they assigned me Amy, and we had this great working relationship, and she fixed me right up after a few weeks, and I was so happy. And that was November of 2014. 8 weeks later, I have my aortic dissection. And according to Amy,
we were just talking about this today.
I called her from the hospital. I was like, can you help me? I had an aortic dissection. I didn't even know that I was going to be afforded cardiac rehab. I had zero recollection of this phone call. Like, I can't believe I even knew where the phone was in this room. I never even found the shower. So I called her and asked her about this. And I think your response was,
well, so she asked me, she's like, I don't know if you remember me. I saw you for my feet. I just had a dissecting aortic aneurysm. I had my life saved. I'm in the hospital right now. Is this something that you treat? I'm like, well, I actually had never heard of that before. So I was like, what are your symptoms? And she said, I can't feel my arm. My arm's numb. I'm really out of breath. I have no energy at all. Everything feels weak. I'm like, well, those are things we treat. I'm like, sure. I'm like, as long as they give you a physical therapy script, sure.
And I hadn't even come home yet, but I already knew that arterial line that goes up the right arm left me, like numb. And I'm still over 10 years later, have like pins and needles. But so we talked about it, and, I came home, and it was about probably 3 or 4 weeks later, once I was home and settled. I had not yet received a script for cardiac rehab. I didn't even know what was involved, but I was hearing the rumblings that I might not be approved from my insurance because I didn't have valve replacement. So I just had my valve resuspended. And typically that's not covered by insurance. And I was not on Medicare yet. I was still in private insurance. So fast forward, time for my first appointment. I think I walked in the same flannel shirt I had been wearing for 4 weeks. I don't know, but I remember you said I was holding my heart
So,
pillow
your heart pillow.
and
Yep.
shuffled my way, hunched over because I still couldn't even stand up straight yet. And we went to a private room because a lot of times in PT offices, it's all on this open floor. It's like a gym floor. We went into a private room, and I think I just remember crying. So I felt I was having a lot of emotional issues. I was having some of these physical, but still, I really was like gobsmacked. I had no idea what had happened to me. And I will never forget one of the very first things that we did, which was
The breathing.
tell
Breathing
everybody
exercises.
a little bit about breathing exercises.
So I just want to like caveat of PT. So Karen was, approved. We got her script. We knew she was at least safe to come in and work with me. So we started with just diaphragmatic breathing was the first thing. So just so much for getting that nervous system calmed down, making sure that you're using your diaphragm appropriately. You're not using the accessory muscles, shrugging in the shoulders and feeding into that tightness and that stress that she already had. We actually, I don't even think we sat up really. Most of the first
No.
session we did it laying down. So that's that diaphragm breathing is that big buzzword. There's so many different ways to do it, laying down, sitting up before you run, before you're walking. But we just did some laying down, and that calms everything down. It gets you more in a better mental and physical state before you even start any exercising.
Yeah.
So it's so appropriate. It's and for anything, for people that are just having a panic attack or people that are trying to work on their cardiovascular endurance and run marathons. It's important. So that was our first step. I think we worked on that a lot. Breathing in the heart
We did.
pillow and
We did, and it was more. What it really did for me is it made me feel secure that I was actually alive. It sounds so silly now when I look back, but just gaining some control over my breath, and understanding that this was actually working out my lungs. It was working. It wasn't just using that spirometer. That
yeah, that's right.
I forget what the other word is. Not inspiration.
Incentive spirometer.
Incentive, not inspiration. The incentive spirometer.
Uh-huh.
This was different. I could just put my hands on my own body, and I all of a sudden started to feel a sense of control on my portion and what I was doing. And then I think we went right into the desensitizing the numb arm. And what did we do for that?
So we use different surfaces. So I think we start with a Q-tip and then a pillowcase. Like you want as gentle as material as possible. We went over all the areas that are numb because that's more time sensitive. The breathing you could work on for forever and include at any point in time in your treatment. The desensitization exercises, you have a certain amount of time to try to regain that nerve connection and the nerves regrow. So we use different surfaces to help with that. So we started gentle and then we got rougher. So we went to like a glove surface, a towel. Forget what else we would use after that. Maybe like a wooden, like a little wooden
The end of the Q-tip.
yeah, the end of the Q-tip. Just trying to get more aggressive because if you start with something like the end of the Q-tip or a towel,
I wouldn't have come back.
they can't tolerate it, and then it sends the nerve system in a way overdrive, and then it sends out too many signals, and then you're backtracking. So starting slow and then regaining that back, so you can take the arm from numb to try and get some sensation back and trying to get to more normal. And you touched on that. You don't always get all of it back, but if you're working on it efficiently, quickly, you can get some sensation back.
Yeah, very quickly I was able to let the water from the shower hit my arm and actually slip my arm into the sleeve. And this was wintertime, so it was very important that clothes, they had to touch my arm. But that was something that we worked on. And from there, eventually we worked on just proper sitting in a chair, trying the further we got towards the end of those first 12 weeks to stand with a little bit more posture, a little bit more upright. And that's pretty much most of what we focused on before we moved on to some of the things that you might find in cardiac rehab. And so before I touch upon some of the differences, I know there were some things you wanted to talk about when it comes to PT, because I've been at this with you for many, many years. I didn't leave for a very long time. What she doesn't know is I was afraid to leave because I thought if I left, something horrible would happen. Because when you develop routines after this, it plays with the PTSD. And I thought if there ever is an end date, screwed. But there was an end date. I was probably the longest patient. I'm probably the longest patient you'll have for a long time.
Yeah.
I was there for a couple of years.
But
Yeah.
I think the biggest thing of PT is making sure it's medically necessary,
And it
right?
was.
Because you have to you have to make sure your PT is comfortable writing
Yeah.
medically necessary notes.
Yeah.
You have to look at what the insurance plan is, because everyone's insurance plan is different, and sometimes they won't let you come for so
Right.
many visits. And we were lucky enough to be able to
Yeah.
treat and really work on things. But the PT side of things, it's just so individualized. So, cardiac rehab, again, it's not, I haven't participated in that, so I can't tell you all the specifics, but I can tell you on the PT side, you're more individualized. You're working, it can be as personalized as you want it to be. You could be one-on-one the entire time in the session in some clinics. Other clinics, you're one-on-one with the therapist. You don't have to interact with anyone. A therapist may be interacting with other patients, but you don't have to interact with anyone else. If you just need that time by yourself, you need to be in the quiet space in the clinic, instead of being in like a group exercise atmosphere. And if you're not ready to exercise at the level that cardiac rehab has you do, it's a great option, because we didn't exercise cardiovascularly for a while. We did things that were way to lead up to that. So working on your vitals, which we do as well. So cardiac rehab, you're working on, you get that monitor of everything. We would do the same thing in here. So we have access to taking blood pressure, taking your O2 sats, and taking your heart rate.
Let's
Let's
break down these differences. If I had a chart, I would be saying in cardiac rehab, usually most people meet with a nurse one-on-one before they ever hit the floor. And that nurse wants to find out, is there comorbidities? What are there some issues that you feel you were experiencing before the need to bring you in here? Same exact type of conversation that I had with you.
Just with
An intake, right? It's just with a PT. Then the big first difference is in cardiac rehab, you are in a room with many other people. Could be 2 people, could be 10 people. And it may fluctuate each time you go, because a lot of these people had actual surgeries on their heart. It's very different when it's just the aorta and nothing of your heart's involved. This is why I think so many people are challenged with insurance. That's a big difference than coming into PT and being able to be much more one-on-one until you're comfortable being out on the floor. And you had mentioned the monitoring, and in cardiac rehab, they put the EKG monitors on you all the time.
We don't have
Yeah,
that.
you carry around a little pocket heart monitor. They're watching you on a screen. So whether you just stand up on a treadmill and walk for a minute, they can see fluctuations. They can take your blood pressure while you're on a machine. They can take your oxygen and your pulse. But you can do all of that. You just don't have the EKG.
You just don't have the EKG.
Right.
And it's not a constant monitoring. Like I'm relying on that patient to be able to truthfully tell me symptomatically how they're feeling, and know that, that there's going to be some personal accountability. Like they're going to have to say if they're not feeling well. Because we can do, usually it's a before, during, after measure. So you're getting an O2 sat, a heart rate, of blood pressure, maybe taking it once in the middle after you do some exercises before you would do like manual treatment, and then at the end. But it's not a constant monitoring. And thinking of that, that's in addition to the exercise and the other things we do, the breathing, the desensitization work, there's the manual treatment.
And there's
That's a
no
big
manual
difference.
in rehab. There isn't. There's no manual. And the other thing too is when you're in cardiac rehab, there is no personalized plan. I believe it's just like a script comes over, this person needs cardiac rehab. So everybody's doing the same thing. Everybody's going to get on a bike, going to get on a treadmill, going to use little 2-pound weights, and you eventually just move through it like a circuit. When it's with a PT, when it's with a therapist, a physical therapist, they are typically getting a script, probably from your cardiologist or your surgeon, that says, this is where top range blood pressure is, right? I think we've had that a few times. Yeah. Top range heart rate, recovery in the midst of working out. Like we had all of that planned, and you provide all of the results, right, to the physicians.
We have daily notes that they could see, the initial evaluation and a progress note, which is done about every 30 days. That gets sent over. Daily notes don't get automatically sent over, but certainly if a doctor wants them, we could provide them, because there's a note for every visit that you're in here.
Right.
Daily notes not as detailed, but for someone that's in here with vital sign issues, that's going to be in the daily note.
Right. And I think the other difference too is in a lot of cardiac rehabs, you might have the opportunity to be provided education. So that could be diet and nutrition. It's just going to be talked to everybody as they're pedaling and doing things. Smoking cessation tips, mental health and stuff of that nature. Because remember, the majority of people that are in cardiac rehab had a bypass, or they had valves repaired and replaced. There are really not a lot of people go in there that have issues with their aorta in and of itself. you're not going to have that same educational class. You're not going to have that at all in physical therapy. Although you can discuss, you can say to your therapist, like I've said to you a lot of times, I think I'd like to try doing some workouts in water where I feel enveloped and I feel safe and I can't fall down and hurt myself. And you can customize a plan for me that would work, that I can do, because you already know the parameters of what the doctor said I can and can't do. So again, I feel like there's just this deep sense of a lot of one-on-one personalized care. And when we did this before I ever even went to cardiac rehab. I evidently called you from the hospital and was, yeah, let's get this scheduled immediately. And where do you think the benefits are as soon as your physician says, yes, you can go to PT? Why is it so beneficial to just take advantage of that right away versus waiting until cardiac rehab? Where do you see how the two fit in really well together?
Well, you were able to get to so much more, and I think get more out of cardiac rehab. If you haven't gotten any of that, yes, some time may have passed before cardiac rehab, but you may have been going in there with an arm that was still numb. You had no idea how to properly breathe. So then maybe your vital signs are getting out of whack quicker and you're not getting the most out of session, or I'm not sure how it works in there if they stop you if your heart rate gets a certain level, and you may have a hard time recovering because you weren't learned all those techniques before, how to breathe, how to even just postural muscle strength, but just even having good posture before you do the cardio.
Well, and also when I came to you in PT, people were still driving me in a car. That's how early on it was. By the time I got to cardiac rehab, I could drive myself. So it wasn't on pain meds. It wasn't loopy, although it was a little loopy from some of the blood pressure meds, but I would go by myself and then I would come home. So I know when I go back and look at the time frame, I was definitely prepared for what was going to happen in cardiac rehab.
And you could know what questions to ask, because there are some things that we may have talked about that I can't answer. I was said, well, I don't know, you need to ask your doctor that, or even having a nurse there the whole time in cardiac rehab, then you could say, oh yeah, I didn't get that information from Amy. Let me ask while I'm here.
Talk about one thing that I know is similar is in both situations, they will talk about your rate of perceived, is it exertion? I want to say exhaustion because mine would have always been exhaustion. Explain what the RPEs are. I know we do this in the aortic dissection and aortic disease patient guides, but explain to everybody what RPEs are.
So there's two scales out there. So you have to just see which one your therapist is using. We usually have them on the treadmills. I think that's what it's usually on the cardiac rehab equipment, but it either starts at 0 or 6 for whatever reason. 6 is the lowest number for the one, but that's more the subjective. So that's really what we rely on a lot in PT too. If I can't constantly monitor you, so it's how challenging or tough or exhausted you feel at that point in time, depending on what you're doing. So we usually get an RP with the vital signs before, during, and after. And that's just an easier way to shout out to people, hey, I'm not getting your blood pressure right now, but I see that you're on this exercise. Give me an RP. And the person will answer back to you. So I guess similar like a pain scale where the person can just objectively tell you, I'm not doing any numerical monitoring for that. That's just a subjective scale that someone's telling you 0 to 10, 0, no effort at all. 10, you're completely exhausted. You cannot move on anymore. You can't do another step.
And I think I remember vaguely in cardiac rehab, they showed me like the pain scale, but it looked like faces of exertion.
So
and
it's comparable.
And when I did this here, one of the many times I came back because I have a lot of other issues. Like I've told you guys, I have Crohn's, so that's exhausting. And it made things challenging. It was a lot of stop, it. I'm going to do it now again, Amy, here I come. But I can remember when we did a lot of that RPE work. And after many sessions, I could see that my rate of perceived exertion was really going down, which was amazing. And I was lasting a little bit longer and a little bit longer. So I think it also allows you visually to see how you're progressing. And if you can get into PT before cardiac rehab, you do have a sense of comfortability and what's the word I'm thinking of when you feel, oh God, secure is a good one. Keep going. Let's keep going. You definitely, the word's not coming to me, people. It's not coming to me. You feel, somebody out there say the word that I'm thinking. I can't think of it right now. Sorry, but I definitely
confident.
Is that what
that was it? I was going to try to say thank you. I was going to try to say the sentence again and again, and I still can. But yes, you feel a sense of confidence, and so I think it makes your experience even with rehab more fulfilling because you're going in feeling like, I think I can do this now. So I know you have things on your paperwork. Is there stuff that we haven't addressed before we do a quick shout out and see if there's people here with us tonight? Or you can just go through it all.
Well, the one piece was following up with the doctor, the script, because that's the big thing, because not all physical therapists may be comfortable or know anything about aortic aneurysms.
Yeah.
So I just am lucky enough to have known you and know about it, and would
Mhm.
feel comfortable if someone just came with a script, but not everyone would. So I think it's also making sure whoever you call, if you have a local physical therapist or a local area that you go to, that there's an open line of communication between the doctor and the PT. Make sure your doctor's comfortable writing down the levels, just a little bit about what your goals are, because the diseases or the diagnosis for PTs can be overwhelming, but when you really break it down,
Mhm.
it's things we see every day. You know,
True.
it's just, so I think that's making sure your doctor's comfortable with that line of communication so the PT feels comfortable.
And to what you were just saying, we've had times even 10 years later, knowing how vastly different my circulatory system is.
Mhm.
If I'm given exercises, because I've had frozen shoulder twice now, different shoulders, really, because, well, the one was definitely because of this. When you have an emergency, they just throw your arms out to the side. They don't care.
Okay.
And I didn't know for a long time that was frozen shoulder, and freezing is horribly painful. But when I had to do some exercises, wall crawls, right? And after doing so many, I would tell you that my arms just would start to feel numb. Like I don't have feeling. They just were very weak. And it wasn't that I was lack of exercise or stamina or working. It was circulation. And once you understood that, you could make adjustments for that.
Right, because then the therapist can tell you, okay, that's normal, you can push through it or not push through that, because
Yeah.
those are two very different things. If it's just a frozen shoulder patient coming in, they
Mhm.
don't have the medical history that you do,
Yeah.
you'd automatically 100% say push through that pain.
Right.
But knowing you, that's not always the answer. It's not always the same answer for everyone. Everyone's individualized. The other thing I was talking about with the cardiac rehab and PT difference is plan of care.
Mhm.
So plan of care in here, I think cardiac rehab, what did you do every day for a certain number of weeks?
I think it was 3 times a week for like 3 months, I want to say. Yeah.
Okay, all right.
It was,
So
I don't remember being every day. I can't imagine I would ever commit to an everyday.
An everyday
You
thing.
know me long enough. I probably wouldn't have done that.
but
So yeah.
PT is not quite as frequent
Yeah.
as that. I mean, it's sometimes
Can
3
be.
times a week, it could
Right.
be, but you may also be 1 or 2 times. You have to,
Mhm.
again, you have to be thinking about the insurance company for that
Right.
and spreading out your visits or doing what you need
Yeah.
to. And then usually it's a reevaluating about every 4 weeks.
Right.
So if you're trying to work on strength gains, it can be up to 12 weeks.
Mhm.
If maybe you're further along and you just need to tune up on things, maybe it's not as long,
Right.
but it's as long as it's appropriate for you. The PT can
Mhm.
write good functional notes, you're making
Mhm.
progress, and the insurance company, because unfortunately, as we go further and further
Yeah.
into this medical world, insurance companies are having more and more of a say. So we do need to
Yeah.
be mindful of that, so the patient's not surprised financially.
And to that point, like I think I remember rehab was covered by the insurance. I don't think there was a copay, because it became a standard part of care after you have open heart surgery or your heart's been manipulated. You do need that special approval if you still retained your own natural tissue in your valve, but PT's not normally covered at 100% by any insurance. So there's a nice copay that you might have to pay. And so to your point, you want to have that plan of care and figure out what's going to work best to make your money, you know, work for you, last the longest, and get the most out of it.
And usually when you call front desk, they should be telling you your benefits before you'd sign up
Right.
for anything. They'd be running your insurance. They don't necessarily know exactly what it is. They know what a
Mhm.
copay is for you.
Yeah.
But if you have a co-insurance, they're not going to know exactly
Right.
what that cost is. So you're really going to have to look at that, because it's a financial piece to
Mhm.
things now
Yeah.
with access to care.
I think one of the other differences that I really like, because again, differences does not mean negative. It's not necessarily a positive or a negative, is that when you're in cardiac rehab, you don't really get a chance to really be a participant in your care. There is a list of things and they must check off that you've
Mhm.
accomplished these things. End of discussion. You don't get to just sit there and say, I'm not doing it because I don't like it. Believe me, I do not like inclines on my treadmill, but I had to, you have to pass it and get a certificate. So Yeah, you don't get to do that. But in PT, if they say, would you like heat or would you like ice? I'm like, oh, I have a choice. It's like a menu. I get to choose, right? I get to choose if today's a really bad day for me and I don't want to stay longer to have stem treatment. And you can explain what that is, or I'm not feeling comfortable. I get to become part of that plan of care with Amy, or you would be able to do that with your own therapist. So what exactly goes down with the stem? What is that, and why would people have that?
So e-stim, again, it's making sure that you're open lines of communication with the doctor and that you're approved for it,
Okay.
because there's some contraindications to it. Pacemaker in, any implantable devices, like people have implantable spine stimulators in, active cancer for yourself. So there's a couple of different contraindications to it, which PT should know and be able to talk you through. Honestly, you should be going through that in the initial eval if your PT is going through a complete one. But e-stim is helpful for a couple different principles. You can either do it for pain modulation and actually the desensitization work too, because it's speeding up blood flow. It's working on the certain type muscle fibers that control pain, but it's also can be for muscle strength. So we can put it on muscles and do a certain setting that helps strengthen the muscle. It's a little bit more uncomfortable feeling since the stem's actually contracting the muscle for you, but there's two different principles. So it just depends on what you're working on. I would say we primarily use it for pain modulation and swelling and things. So that's the more comfortable one that people love.
Yeah.
Yep, and they can fall asleep with, and it's paired with heat or ice. But I realize it's the pain modulation and the swelling that we use it on.
Desensitization, you just made me remember, we didn't stop at the arm. There's a lot of you, if not all of you, that have pain and some uncomfortability when the nerves are regenerating around your sternum, incision. And we did work there too. There was a little bit of desensitization. Explain, how did we do that? I can't really remember, but I know we did it around the sternum area.
So that was a little more aggressive around the incision. So you have to make sure that the incision's healed. Therapist wearing gloves right in the area, and that you're in a comfortable private area because you want the incision exposed to work on it. But we start with just gloves and going perpendicular to the incision. So there's an incision's running down this way, you're pressing perpendicular and trying to get the incision to move some, because even though it's not a muscle that you think of like your elbow or your knee that's getting a lot of tension, you're still, if you're moving or rotating, looking to drive, rolling in bed, that area gets a lot of stress tension. So the skin has to move or it's yanking at that incision.
Now I remember when, as soon as you made that movement with your hands, I'm like, oh God, I remember.
So you're trying to, now you can go up along the incision, but you're going to get more mobility work if you're going perpendicular. So you're either doing that with gloves, you're teaching the patient to do it. I think that's another big thing of PT. It's taking ownership of the patient, showing them what to do at home, whether it's the scar mobility, the breathing, other exercises, going for walks, how to monitor your rate of perceived exertion. And then we use the towel to go around the incision to desensitize. So you're working on mobility and the sensitivity.
And it worked. It helped. And when I hear a lot of people talk about how uncomfortable they are, I don't hear a lot of people talk about what they're doing other than maybe lidocaine patches if your doctor approves you for that. And so just know that you're not going to have that in cardiac rehab. Cardiac rehab is rehab, and it's great. And it's a super important tool. And I wish everybody would be approved for it. But if you're not, this is another benefit of PT, is to be able to try to get those nerves turned on, try to get things to heal. It's not pleasant. It's not painful, but it's like, if someone came over and just did this, and then it's annoying. It's nails down a chalkboard, but it's working.
And you'd rather that than be rolling in bed and waking you up at night because your incision feels like it's ripping open. You'd rather do some kind of work there.
Something, exactly. So I want to just check in and see if we have anybody with us tonight on beautiful weather night. I don't know where it's beautiful everywhere across the country, but it certainly is here in Maryland. So we can say hi to everybody.
So far we have Tobias in the chat. He says, "Hello girls, I have a question."
Sure.
Is it possible to make some exercises for feet maybe?
Is it possible to make, are there exercises for feet? This is separate from aortic disease, obviously, but is there an exercise to, there's probably exercises to strengthen feet.
Yeah, to strengthen and stretch it. Stretching feet. Is it like he's asking for this now? Like,
Evidently, I mean,
Okay.
these wouldn't be ones that you're necessarily telling him to do, but you would just tell.
oh yeah,
anybody,
if
'cause
anyone
depending
was
on their
that,
problem,
yeah. So if it's a stretching issue in the foot, you'd think about the two gastroc or soleus stretches are the two that come to mind. So usually you're seeing like a runner stretch, like someone stretching their foot up against the wall with the knee straight or bent, because that gets your calf, but also the bottom of the foot stretched out. Strengthening for the feet would be more like toe curls or like making an arch with your foot, trying to contract the toes or the bottom of the foot, or calf raises. That would be another, would be completely opposite of the stretching. The calf raise is working on the strength.
I even think we did some of that because
did.
I think the dizzy,
Full body.
yes, and then we moved it into the pool. Because I needed to strengthen my ankles because the medications were just making me, everything was so dizzy. I mean, everything, when you have those surgeries, things can change, but interesting question. Thank you for asking it. Thank you for asking it. All right, have we missed anything else that's on your papers?
No,
Feel
I
free.
know I looked at everything. So
You
that
did.
the last thing was the plan of care.
Okay, all right.
So we have
Well,
that.
So-
hold on, before
Yeah.
you run away.
what's running?
There's a question that I've had for a while, and it is,
Okay.
for some people, especially the younger people in the dissection community, they want to get back to doing like, not exactly yoga, but like downward facing dog, or they want to be able to do like a push up. What's the timeline that you would prescribe for something along those lines?
Well, I guess timeline would be patient dependent, because there's so many things you have to get to before that. Because even though downward dog would be flexibility, it's aggressive flexibility. Gosh, right off the bat, you'd have to be at least 12 weeks, because 12 weeks is when we start strengthening.
Okay, that's good to hear.
So it's at least 12 weeks, and then it goes from there, because push up is a lot of stress. So then you'd be at that 12 weeks when you started strengthening, you could be doing now obviously it's dependent. 12 weeks is the conservative side. If the person's ready for it, you can start simple strengthening, like wall push-ups or push-ups on a step, or push-ups on a lower step, and then before you get down to the floor. So there's certain progressions to it too when they're ready for strengthening. Same thing with the downward dog. You're starting with something more inclined first, like they're doing that a pulley stretch first, where they're more upright, and then you're doing a barrel stretch where you're holding onto a counter and then coming down. So it's working down to that position where you have a lot of pressure, and gravity's putting a lot of pressure on you.
And remember, it takes about 12 weeks for the sternum to heal, like it would if you broke clear through your leg. It's
right.
gonna take time for those bones to knit together. So I'm not thinking downward dog's gonna feel comfortable.
No, that's
when your
gonna be a
bone's
lot
not
of pressure.
knitted.
But
Yeah.
so it's starting with the simple. So that's your goal, and then you have to do easier. Start with that most basic movement, and then work up to it from there. Yeah.
Okay, thank you very much for that. One of our programs is Qigong with Kevin Songer, and he got involved with Qigong because he was stuck in a recliner for quite some time, and he started to feel like he was losing a lot of muscle in his shoulders. And so his wife is the one who kind of introduced him to Qigong, and then he ran with it like crazy. When can somebody start to think about moving like that? Super early, or?
That's
Such slow movements that I would think you probably could do it at least in a chair if you felt, and if you felt stable enough, then the doctor says go for it. Again, I believe that 12 weeks is a good marker, just because like any bone, you need the bone, you need the time for it to heal. You're figuring out your medications and everything. But again, if you're somebody and you're waiting for your bone to heal, as long as you're not twisting and turning, moving your arms slowly, anything slowly and fluid, as soon as the doctor says you can get up and move, and as soon as the patient feels like they're not in excruciating pain, because moving the arms, moving anything is moving skin, it's pain,
the pec stretching. And excuse me, you have to think of like that's active motion. So then again, we'd break that down and do active assistive. So like your pulleys or your wall slides. And then passive before that, which is where the PT comes in. Passive stretching, like we would stretch you, we'd get that range back, because you have to have that range to do it before you do something actively. So it's looking at whatever that patient's goal is, which is so nice, because we get to talk about those individual goals in PT and then break it down from there. Because that's where you want to end with, when are we allowed to do it, one, and then is there anything we can do to push that boundary and work up to it so you're ready to go before then.
Oh gosh, and using those pulleys, I mean, after the frozen shoulder, you know, you would say, okay, just pull your arm up. And I would be pulling and I would be like, oh God, I'm pulling and it hurts. And you're fully in control, but it's just so weird to have an arm that's not working, but you're using the other one to kind of take it to its limit, you know, and that's not anything you're doing after your sternum's been opened, for sure. Like that's just way too much stretching of all those muscles that were cut apart. So that does take time to get to it. But there's so many other things you can do that would be nice, slow breathing and fluid movement. I mean, even just from trying to turn your head, you know, because that's probably jacked up as well.
Or isometrics, or so strengthening in the lower body too, like just doing even core. We call it the transverse abdominis. So core work is big. Glute strengthening, even ankle pumps, just pumping the foot up and down.
Blood going. I remember we worked on getting from a laying down position. They don't really teach you that well in a hospital. They tell you need to roll on your side and push up, but the heck if you remember how to do that. So we were in here and I remember working on that, you know, just rolling on the side and figuring out how to roll off the table, which would be like off of the bed, basically.
Because you're getting they're saying roll like a log, but you're getting so much education right afterwards. You don't like, you didn't remember even calling me.
I had no idea.
So you're getting all that information. It's just nice to take it back to the basics and review it, where in case that's missed during cardiac rehab, because like you said, there's check boxes that need to be done. I don't have any check boxes. Like I'm making them.
Exactly.
I'm making them with you. I'm making our check boxes the first visit, and then we're seeing if we've met those.
Okay. I like all of that too. So as I understand it, when Karen comes to see you, it's pretty relatively early after her dissection, and she's walking.
Yeah.
Right.
Yeah. Yes, you were walking.
I was walking. Well, yeah, it was after I finally gave up a wheelchair because somebody told me you can actually walk, stop using a transport chair. I had no faith that walking would be safe for me. And I remember walking in, slumped over.
I was just gonna say you were walking, but it wasn't good functional walking. No, you were just kind of slouching, slumping back to the room, but you were walking on your own.
By the time I got back to the room, I was exhausted. I hadn't changed meds yet, nothing. And so to be able to lay down and be just, you know, you're just going through the motions, but at least I'm moving my body. You know, I had forced my legs to move, that moved blood flow. When people would say, go to the mall and walk, I fought them hard because I just didn't think that it felt safe, but I knew I felt safe when I was in this office. I felt safe.
You're under the care of us. We know that if there's something that I can't address, that then we can always ask the doctor for it. And
there were some dizzy spells that were pretty gnarly there for a while, that we would have to get the blood pressure cuff and just sit and steady
and lay down. And that's where the ankle pumps would come into. And
so it's good to do that and to have somebody else monitoring you versus trying to take on any of that kind of movement on your own.
Listening to someone that just says, go out and walk at the mall. Maybe you'd be appropriate for that later on, but how do you monitor yourself?
Exactly.
Excellent. So you spoke about the desensitization exercising. And so a follow-up question that I would have is about how long before you can start exploring massage? This is a famous question that we get in our support groups by all new people.
Physiologically, it has nothing to do with, it has more to do with pain, because right away you can have somebody rub your legs. You know, that's just blood circulation. It's all good things. Unlike pregnant women who after a certain point shouldn't have massage because it can stimulate, you know, bringing on labor. Having, you know, your hands rubbed feels good. Nurses would come in your room and put lotion on you or your feet and your legs. That's all great. But nobody is going to be laying on their sternum for any time soon after having surgery. Even laying flat on your back in some of these tables, not very comfortable. But
the tension on the pecs with doing that.
Letting your shoulders fall back, it's too hard. So bringing the head upright and having somebody gently go behind your back, even to stroke up the spine, is still, even though you're in a rib cage, it still can force your chest forward. So I don't think I did anything like that probably for the first year.
Yeah, we're not.
I didn't even wash my own hair. I would go someplace and pay money. My father would take me and pay money to have somebody wash and blow dry my hair because I didn't have enough arm strength or circulation to do that on my own.
So I just know there's no restrictions on that is the big answer. It's just, I don't know how much it's tolerated by the person.
Yeah. So I think it by the time a patient feels like they could tolerate it, the physician would say, go for it.
Okay.
You can't hurt somebody by pushing on someone's back. Your aorta, even though it's more towards the back, you're in a rib cage, and our organs don't just sit there. They fall forward, intestines scooch over here. Like everything is moving right inside the body. So it's never necessarily in the same place twice. So you don't have to worry about if someone's giving you a massage that they're going to push on your aorta. That's just not happening.
Okay, right. And again, a lot of these questions are coming from people that are like 6 and 10 months out of their original dissection, right? So let me
So
check
if they
and
feel
see.
like they want it, they should try it if
Yeah.
they're given a green light.
And you could do massage, like massage therapy,
Mhm.
or the PT
Right.
side of things can do massage techniques. Now, it's not
Yeah.
just going to be just massage techniques in isolation. There's going to be some exercising with
Right.
that too,
Yeah.
but that's an option too that PTs could do.
Mhm.
Okay. All right. And there are no anonymous questions.
Okay. That's an easy evening for us. And getting back to the massage, I think I remember the very first one I ever did was like a pregnancy massage. So I stayed on my side.
You were on your side. Yeah.
This way they could still rub my
Yeah.
back and it wasn't heavy pressure, and I could determine where I wanted my shoulders to fall. I knew I didn't want to lay on my stomach. There was no way I was
Yeah,
doing
that'll
that.
be a lot of pressure because
Yeah.
you're thinking about not the risk on the aorta, like you said, when you're
Right.
that far out, it's the muscle tension
Exactly.
that's associated with just protecting yourself
Exactly.
so much
Exactly.
after surgery.
Yeah. So I guess the long and short of this, for people that end up watching this video, is there is no there isn't a situation where you don't have an option to begin your recovery of aortic disease, whether it's having valve replacement, having an aneurysm repaired, whether it's endovascular, whether it's open. If you're not granted the opportunity to have cardiac rehab, regardless of rehab, consider starting with physical therapy. Talk to your physician about that, because I really do think that the benefits, there's only benefits. There's really no benefit.
But if your physical therapist is worried about anything,
Mhm.
they're going to go through that with you. Even if the doctor signs off on PT, the PT could still say to you, I have reservations, but there's always going to be something you can work on.
Right.
It just may not be at the top level. Maybe you need to work up to that cardio piece,
Mhm.
but there's something you could work on. Breathing, postural strengthening, something.
And even if your physical therapist hasn't come across somebody with aortic disease or dissection or valve repair, it's what you're coming in with, the
Mhm.
symptoms
The
that they're
symptoms, yeah,
treating.
yeah.
It's not the diagnosis of what the end result was. It's the symptoms.
Yeah, and so that's the big thing that may scare. Well, I haven't seen that before, but talk to them about what are they experiencing on a day to day. And that's usually one of the first questions I ask someone
Mhm.
is, what's a typical day like for you? What are you struggling with? And then
Yeah.
that's where you'll get some of those answers.
And I also agree that it's a great tool, because unlike rehab, you typically come in and fill out this big questionnaire that says, where are you when it comes to bathing yourself or cooking for yourself or standing or stooping? Are there any things that that you have to do in day to day that you're struggling with? What's it on a scale of 1 to 10? So you've got these answers and how you're feeling. And then you find maybe 4 weeks later, your answers are so much better. And I think for a lot of people, after something like this, it's so shocking. We don't see our recovery. We just don't. We're used to seeing it day to day, and you're not going to see anything day to day. But this is just another tool that you can go back, and when you have to answer these questions, you'll see, because your therapist should say, well, this is great.
Mhm. They
You
should
always
be
do that.
improving.
You
Yeah.
know, this is so good, Karen. This is great. Because look where you were and look where you are today.
Yeah.
And it really, it adds to that confidence builder.
Mhm. And it's subjective and objective, right? Because
Exactly.
we're taking the objective measures and I can see where you're improving numerically,
Yeah.
which is huge for people. They
Yeah.
like that numerical number improvement, but it's subjective. Look at this number that
Exactly.
you were on the subjective scale now and look at it now. And then that just keeps you motivated to move
Right.
forward.
It just gives
Yeah.
you that boost so that when and hopefully you are granted cardiac rehab, you go in there more confident. That's the
Mhm.
word of the night, confident, and you'll be able to tackle that with a little bit more ease and less trepidation. So, Amy, this is number 2. You knocked it out of the park.
2 years later.
I know, no baby about ready to
Yeah.
pop out like 24 hours later. This is wonderful. So thank you. Thank you so much. We do have information up on YouTube in case someone wants to ask Amy a question, or you are in the Maryland metro area and you feel like you want to talk to Amy for anything. It could be plantar fasciitis. It could be
Mhm.
your tennis elbow from too much pickleball, whatever it is, you can reach out to her. I highly recommend Amy, but definitely take this conversation back to your physician. You know, it probably makes sense. You know what, even if it was a year or 2 ago and you never got cardiac rehab and you never got PT,
Not too late.
never too
Mhm.
late. I've been at this for 10 years. Trust me, I keep coming back.
Mhm.
So it's never too late. Thank you again so much for
Thanks,
being here.
Karen.
You're welcome. Everybody do me a favor, click like, click subscribe, hit that bell so you're notified the next time we're going to go live. And I will see you guys soon. Thanks so much. Take care.